Hello, good afternoon, everyone. On behalf of the Department of Health, I'd like to thank the organizers of today's session, APMC and PASCOM, for this opportunity to share with you the role of specialists within the UHC scheme. Very quickly, UHC law was passed in February 2019, and the IRR was published 6 months later in October. The goal of the law was to make sure that we optimize this box, that the pooled funds that are available to us will cover as much of the population, actually all of Filipinos, more services, particularly primary care, and reduce cost sharing and fees in accessing all of these services. UHC, in summary, aims to provide healthy living, schooling, and working environments in consideration of the impact of social determinants of health, that every Filipino family will have a primary care provider, that health spending is predictable, but not everything will be free, especially the fringe services. And then finally, that the care will be provided for by providers organized as integrated networks. We go back to this diagram, a very informative diagram that tells us that as much as 80% of what constitutes the health of any population does not happen within the bounds of clinics and hospitals. But in fact, they are a product of socioeconomic factors, physical environment, and health behaviors. Hence, our interventions will also have to be commensurate to these factors. UHC puts a very strong emphasis on health promotion and disease prevention in all settings, and that's why the DOH has published its health promotion framework strategy prioritizing these 7 areas. We also, as per the law, need to prioritize interventions in places where people spend most of their time, and that's not clinics and hospitals. No, most people spend their time in the communities, schools, and workplace. And we have existing collaboration with our partners in national government agencies to implement programs in these spaces. The Secretary of Health has released his 8-point action agenda, which is summarized in the screen that you're seeing here, especially because today our topic cuts across. May some part that's about HRH, so that's item number 7. But definitely we will encompass several agenda items for the topic today. The idea behind the entire UHC reform is that we want to activate whole of system, whole of government, and whole of society collaboration, but very clear also to us that for each and every stakeholder, there are going to be different needs that will have to be negotiated with, not necessarily acceded to, but some of these actually have trade-offs. So if you want, for example, payers to pay for most efficient services, then healthcare workers or clinicians or hospitals might find it that some of the services that they're producing are not going to be reimbursed. So what's the implication for practice? So generally, the UHC law dictates that every Filipino family will have a primary care provider team, and the family consists of a child, adult, could be elderly, and even pregnant woman. And so there's a need to balance competence and confidence, as well as preferences of the physician who's seeing this Filipino family. If I'm a pediatrician, gusto ko bang tumingin ng adult, Kasi I can train some more so that I will be competent and confident to see an adult. If I'm already an adult IM, for example, and I want to also be considered a primary care provider, then I have to be able to see a child, Pero yun nga yung reason bakit ako nag-IM, kasi ayokong tumingin ng bata, So there are things like this that have to be taken into account. In the near term, the idea is really to train the primary care provider in such a way that he or she will be able to serve the entire unit. The option is also to be able to partner with other specialists. So I can be, if I'm a family physician, then I'm expected to be able to do all, diba? But if I'm a practicing IM, then maybe I'll just band together with my friend who's a pediatrician and will apply, no, together as a primary care provider team. So in a fully operational UHC scheme, and this is, I mean, realistically, a generation's worth, no, there will probably likely be specific cadre for primary care already for us. So just to go through what the primary care practice would look like. Again, no, maraming fake news going around, but the UHC law did not prescribe any type of practice structure. But the options would include individual practice, group practice, or perhaps no employed practice. The idea here is you will have to have a heterogeneous mix of healthcare workers because certain things no are not going to be best use of time for the physician. So kunwari, in primary care practice, you want to have more time for counseling, for lifestyle and diet changes. It will not be best use of 1 hour of the physician to actually do this, no, when you actually could have a dietitian on board. So then this points to possibly, no, really the need for task shifting and task sharing formally, because informally we're already actually doing it. Diba? So how about for subspecialists? No, we expect that, of course, there will likely still be subspecialists. The more we screen at the primary care level, the more we can refer up. And in the near term, we expect that the subspecialists are going to always be paid outside of capitation, diba? It will be too expensive to include that as part of primary care payments. And likely, inpatient benefits will continue to be pre-packaged, no, similar to the Z packages that we see now. In a fully operational UHC scheme, we would anticipate that the inpatient payments for subspecialists will technically already be incorporated into the advanced payments or global budget to the hospitals. But for outpatient, likely the same, no, separate siya as how it is in many other countries. For specialist practice, again, the UHC law did not prescribe or limit any practice structure. As such, anything can happen. So, for example, ER practitioners now, they already are employing group practice, no, as well as anesthesia, for example. So that could very well still be the model if they want. There will be, rest assured, everyone, that there will be pilot programs for this. So people need not panic na bukas na ba to, etc. No? There will be a pilot program in 4 to 6 provinces or cities come January of next year. And we will do extensive data collection and have external evaluation system for this. And this is really where new schemes will be tested, new payment schemes. But more importantly, I think implications on practice dito mas mapapag-usapan intensively. We often get asked, can patients directly go to specialists? In the near term, definitely. No? But in the fully operational UHC scheme, so sa near term, yes, diba? Because we don't really have a good primary care system or gatekeeping mechanism in place. Alam nga naman, hindi mo sila pwedeng papuntahin, diba? But in a fully operational UHC scheme, definitely you can go to specialists if you will pay for it out of your own pocket. Yes, if it's emergency and deemed an exempt, no? So pwede kang mag-bypass based on the set of rules. And definitely the answer is no if you want the system to pay for it. No? So you need to have been seen by a lower level practitioner. There are many concerns from specialists about time-sensitive referrals and medications. No? I guess what we really wanted to say is the risk will actually never be zero. The risk that someone will make a mistake. Diba? Kahit ikaw na mismo yung specialist, you can also make a mistake because we're not computers, no, at the end of the day. But we hope that we might be able to mitigate this through the system of which the practitioner operates in. No? So for example, meron talagang clear delineation or task shifting, di ba? So si specialist will do this while si primary care provider will do this. No? Second is for the training curricula, that this delineation is actually embedded, no, in the pre-service and in-service training. Third is to have practice guidelines and make actually tools, like technological tools, like clinical decision support systems, to be made available to the primary care provider. No? So parang hindi matatakot si specialist na, ayokong si primary care yung tumingin ng diabetes patient ko kasi baka mali-mali, no? Or si Ruma, ayoko lang sila yung tumingin kasi baka mali yung diagnosis sa back pain. No? So these are just some of the things that, based on literature, have really helped healthcare providers to not make a mistake or lessen their chances of making mistakes, no? Especially if we're not expecting specialists to actually see these kinds of cases. Now, by me, just to reassure everyone that the government has plans to build facilities, both primary care and hospitals, to fill in the gap that is in our Philippine Health Facility Development Plan. And just to go through some of the slides, we'll share it with you. The pipeline is both for primary care facilities, even for specialty center. No? So hindi totoong ma-wipe out yung specialist under UHC kasi puro primary care lang. Maling-mali po yun. No? So we do have a lot planned because di naman pwedeng puro primary care lang. No? So the UHC law talks about prioritizing primary care, but that the entire pathway of care from primary, secondary to tertiary must be provided, no, as guarantees. Now we go to one of the major areas which has an impact on health human resource. No? And I was asked to talk about implications of UHC on basic medical education. There are two specific provisions within the UHC Act that kind of alludes to capacity building in UHC. One is expansion of existing and new allied and health-related degree and training programs to be done by CHED, TESDA, PRC, and DOH. For everyone's information, the DOH has very limited regulatory authority over the HRH cadre. No? So PRC, in fact, is the regulator for practitioner, while CHED is the regulator for medical schooling. On the other box, it indicates here that CHED, PRC, and DOH, along with medical and allied professional societies, perhaps like PASCOM, shall reorient medical and allied medical professional education and health professional certification and regulation towards primary care competency. So this is a simple diagram that I drew basically to just show you the range of health workers when we talk about HRH. No? So definitely, there are health workers that are clinical in nature. So yun yung mas familiar tayong lahat. And among clinicians, meron kang primary care providers and specialists, di ba? And for both, no, you have doctors, nurses, midwives, and even sa specialists, di ba? Nurses have specializations. But you also need to look at health human resource in terms of those who are experts in policy planning and management, people like in the line of work of administering PhilHealth or managing programs in the DOH, diba? Or your PHOs, no, or MHOs. And then the last column are health workers or health practitioners who are very good in research, no, both in basic, clinical, and policy and systems research. So importante to in light of also us building our very own Philippine CDC, diba? So people like Ma'am Menchit or Doc Eva who or Doc Cynthia Saloma, no? Si Ma'am Cynthia is a non-medical doctor but PhD researcher in genetics, no, kunwari. So we do know that there's a clear gap, and ito is even just for basic cadre of physician, nurse, midwives. No, you can already see the gaps, no, around 100,000 for physicians, etc. And so the three main points that I would want to talk about in this reorientation would be first, production capacity. No, thinking about if we keep on putting out these pre-service scholarship programs, will our problems be solved? No? Actually, hindi. Di ba? Parang stopgap siya because it's reliant on whatever existing programs that we have. No? So we couldn't fill the 100,000 doctor gap just by putting in more scholarships because each school also has limitations. So yun yung question sa atin at sa inyo. No? Parang, how do we ramp up production capacity beyond scholarships, diba? How can we increase number of medical schools? In the same way, what are the other mechanisms to actually produce? No, if we're talking about task shifting, ano yung iba-ibang models, no, of in-service and pre-service training in order to produce the correct worker with the correct competency, not necessarily with the correct degree, diba? So again, no, this slide comes up just because it's really important to think about it, particularly for the medical practitioners who hold so much power. No? So a lot of medical procedures are left to medical doctors in the country, diba? So in other settings, diba, may nurse anesthetist sila, etc. No? Pero tayo hindi, no? Parang the physicians keep that power. But I guess the question is, within the physicians group, what should be our response? Now, if we're saying we want to be a driver of UHC, will keeping all these tasks to ourselves but not being able to produce more people like us, will it really help the country and the people have more access to care? The second would be how can we use schools, no, or learning institutions as already UHC labs, so to speak, no, na nangyayari na yung UHC doon. And we should look at it that learning institutions are not merely producers of the future human resource and future knowledge and experts, no, but learning institutions at this point in time can already be nurturers. No? They have to be healthy learning institutions for their students and healthy workplaces for their faculty, their teaching and non-teaching staff. No? And finally, learning institutions must play a role, no, in building the local health system within their area. No? So definitely, if you have a school clinic, di naman lahat magagawa mo. No? So you have to be able to link outside. But beyond that, the fact that you are in a city or in a municipality or in a specific province, you actually have a lot of political power in terms, or political influence in terms of shaping the politicians' decision in the area to advance UHC further. No? So parang ang call talaga dito is makisama, no? At get yourself involved, kumbaga, in the local health system, UHC development. And then it's also important that we appreciate that we do need to operationalize this issuance and reorientation of health professions education curricula done back in 2021. But really, it's looking at our curriculum and saying, what will make new graduates ready for this new regime of UHC? Different compensation schemes, definitely. But I suppose, no, also different ways of dealing with other healthcare professionals or healthcare workers. And more importantly, very attuned, no, with using technologies in that patient encounter, or even without patient encounter, but it will allow you to improve access to care. No? So for example, there are technologies that are being developed now that the patient who has diabetes, no, can stand on, and the mat, they just need to stand on it for 20 seconds every day, and that maps blood vessels, etc., in the foot of the patient, and it can predict up to 5 weeks before, whether the patient will have a foot ulcer or not, diba? There are tools, for example, wherein just by mere capture of photos, the birth weight, blood pressure, vital signs, no touch of the patient can already be obtained. So parang how can the future healthcare practitioner be able to adapt to these technologies that actually help him or her take care of more people with better quality, but not necessarily that he or she will be the ones doing everything. So with that, the basic call to action to everyone listening today would be first, please help redesign the production system, particularly for medical doctors, and so that we may be able to increase our production capacity. Is this about working with other countries who have surplus production capacity, but actually no one wants to study medicine there? There are many things that we haven't explored. Second is definitely to promote healthy learning institutions. This is a low-hanging fruit in order to be able to facilitate academic, personal, and social development within the school setting. And finally, to be able to operationalize the reorientation of the medical curriculum to produce UHC-ready practitioners. So with that, I thank you for your kind attention at maraming salamat po sa pagbibigay ng attention po sa presentation na to. So thank you, and I hope you have a fruitful conference. Thank you.